Bom dia, Helio.
Bom dia. How are you doing, Adrian?
I'm doing great. How about you?
Oh, great. Thank you.
It's great to have you.
Oh, thank you. Thank you very much for the invitation. So we had problems with Jeff?
Yes, I just spoke with him and he was about to start an emergency craniotomy. So,
Oh,
that is our life. So we'll let him present at a later date because he was trying to tell me, I'll try to finish really fast and I'll see how I can accommodate. And I told him, no, listen, just take care of the case and
sure.
you can always present at a later date.
Yeah, correct. So anytime you want I share my screen, I can do it.
We'll give just a few minutes. We'll wait for Salman Sharif, who is the head of the department and the host of this platform. If not, we'll start in a few minutes. So how is COVID in Brazil now?
At this precise moment, we are very low in numbers.
Oh.
In my institution, for instance, is a public hospital, a big hospital. It was totally devoted to COVID cases. We are now with around 20% of occupation in ICU beds. So that's a number that's very small comparing with some months ago that we had around 100% of occupation with these cases. But we know that we are in summer now, and I think we'll have something next year, just like the other countries, states, and Europe. And what about you?
I think we're starting the second wave. So, cases are rising. We were held back for so long and had very few cases, and now things are starting to get busy again. So we'll see. Okay, let's see if we can start. Oh, there's Salman.
Hi, Adrian. How are you?
Hi, Salman.
Hi, Salman. How are you doing?
Hi, Helio. How are you keeping? You look good.
Oh, fine. Thank you.
Pleasure to see you.
Thank you for the invitation. Nice to see you too.
Wonderful to see you here. I think we have learned, and I've been saying and repeating it again and again. What Adrian has done here is wonderful. He's just collected all the galaxy of these neurosurgery from all over the world and delivered to us. And they have done a great job. Each lecture has been brilliant, and looking forward to your talk today.
Oh, thank you. Thank you very much. Hope you enjoy it.
Hopefully you will.
So I think we're right on the hour, so we can get started, right, Salman?
Yes, definitely, please.
Okay, so dear friends from good morning, good afternoon, and good evening, wherever you might be. Today we are here for yet another session of these pediatric neurosurgery courses. And today we are really delighted to have Helio Rubens Machado as our speaker. Unfortunately, Professor Jeff Lount from UAB in Alabama is about to start an emergency craniotomy. So as you might all understand, he did not want to diminish the nature of his talk, and I instructed him that he can always present at a later date. Helio Rubens, on the other hand, has been a champion of epilepsy surgery for many years now. He has a tremendous experience and is one of the leading figures of epilepsy, not only in Brazil and Latin America, but worldwide. So without further delay, I would like for Helio to share his screen and present his lecture on extratemporal lesionectomies.
Thank you, Adrian. Thank you, Salman. It's a great pleasure and an honor to be here with you today to discuss one of my preferred topics, that is epilepsy surgery in children, and mainly extratemporal resections. You know how difficult this can be. And I have no disclosures. First of all, I want to start saying that epilepsy surgery extratemporal cases in children are much more common than adults. If you compare with adults who have 80% of children having this extratemporal resections, contrary to 25 or less percent comparing in adults. And the other point that I would like to mention is that how quick can be epilepsy can be in these children, the so-called catastrophic epilepsy. This is so important, and so important that we try to do surgery as soon as we can. Although we all know that the surgery is very early in children can be problematic. That's the main reason why these children should be operated on in a pediatric setting. And because they may have typical neurosurgical problems that we pediatric neurosurgeons are used to deal with. As I mentioned, epilepsy surgery should be performed in children very, very early. And in our institution, I think at now, most of the cases we prefer to do before the age of 2. The main reason is to avoid the progression to the terrible case picture of epileptic encephalopathy that will really damage and sometimes in a reversible way in these children. So let's try to do surgery very early. Let's consider, for instance, a child that comes to the neurologist with seizures. In this case, so seizure will provoke some symptoms that will be studied. The symptoms may invade the brain into functional areas, and most of the image studies will show an epileptogenic lesion. And the neurologist will demonstrate a nictal onset zone and an irritative zone. What is the problem for us? The problem is that this epileptogenic zone that we must in any way discover is a theoretical concept and is very frequently larger than the lesion itself. So resecting the lesion in epilepsy in children sometimes it's not enough for stopping surgery. Sorry. These children undergo the same studies that for selection of patients as any patient. They start for a clinical evaluation, a very, very thorough evaluation, because the neurologist should try to find a localization, a hypothesis. This is the start, the beginning of the evaluation, and to find this refractory seizures. The refractoriness will be, as soon as possible, will be defined before the child undergo image studies. And image studies, as you know, we have now many kinds of image studies, starting from MR, mainly for MR specific for epilepsy cases, and other patient cases like exams like FMR or MEG in some centers that if you can have it, or PET and AMP PET for rarely in some centers you may find it, and SPECT. SPECT is more easy, and we can find in the majority of the centers. This all is done before one step, that is the invasive evaluation in children. Mainly, most of the or many children are submitted to or need this invasive evaluation, and this runs from around 20 to 35% of the children, and we'll talk a little bit more about that. And all this, if you consider, for instance, all children, you will try to do surgery with electrocorticography in the half of the cases, but some children will need this invasive evaluation. Focal cortical dysplasia is the main cause of epilepsy in children, and so this will raise the need for invasive evaluation. In our own series, this goes around 20% of invasive evaluation, but we can deal in some children with acute evaluation with electrocorticography. This means that only 15% of the cases can go straight to the surgery, and these are probably a case of temporal lobe surgery and not extratemporal lobe surgery. So invasive evaluation is an important step before surgery. And invasive evaluation are indicated in children when you have inconclusive preoperative data. This means that you must try at any cost to find something in children, and even if you have difficulty with some inconclusive data concerning seizure localization, because video EEG is not congruent with the other data. For instance, with image studies, you must study more deeply these children in order to try to characterize this epileptogenic zone. And one more important thing that you must have is it is so important to have a functional cortical mapping. Why? Because very frequently in extratemporal epilepsy, the eloquent areas are involved. This is so frequent. So it's in order to try to avoid or to depict the invasion of one of those eloquent areas, you should have a functional cortical mapping before you plan your surgery. Either a sensory map, a sensory motor map, a language map when possible. What kind of invasive studies? You know that nowadays stereo EEG has gained so much importance in all over the world, and this is a node technique, let's say like that, because it was it started in the 1950s by this couple of researchers, Jean Taléa and Jean Banco, at the center of Sainte-Anne. Almost of the same time in America, another couple of giants, Penfield and Jasper, created their own model. There are different models. The Penfield-Jasper model is a cortical study. They always operated on their patients, the waking patient, and stimulate the brain. They created a profile of a study of the cortex. And this was later when in the 1980s, when we had the grids and strips covered by silicon, and this was the preferred method worldwide. And the method of Taléa, then now it's so important, came to the world, is different, because is based in a different concept. That is the three-dimensional concept of propagation of the seizure. Knowing in a three-dimensional way, by insertion of these electrodes deeply in the brain, you can have a clinical correlation. They call it that, anatomo-electrical clinical correlation, and creating a 3D network, trying to find the better way to depict the epileptogenic zone. So, well, commonly that was still used is these grids that you place over the cortex, and you can do it acutely as an echography, electrocorticography, or chronic, leaving this in place. And sometimes this can be associated with one or two depth electrodes. The problem with this is that craniotomy is needed. You know that in children, as I said, in small children, this can be problematic because if you need a good cover of the cortex, you may have some problems related to big craniotomy, and it's another big surgery. The difference between this technique and the elegant stereo EEG, that the stereo EEG, these electrodes are placed in a very studied fashion, as you see here, but with small trepanations. So it's much more easy to do, but much more elaborate. You must have a very good hypothesis. If the grid cover a large part of the cortex with this technique, this is very close to the region of the electrode. So you must have previously a good map. This will cover mainly those regions that you cannot access with grids in strips. For instance, the deeper region, the cingulate gyres, the intermediate hemispheric tissue, insula, etc. And in cases that we have failure of the other investigations, or even in when you need to have a bihemispheric exploration. So this is now a very good technique, and it's used worldwide. And as I said, this creates a functional network that the neurologists with the neurosurgeon have to study. Well, as I mentioned, frequently these eloquent areas are invaded or involved in cases of epilepsy extratemporal, either the sensory motor region, the language areas, or deep-seated areas, for instance, the insula or the occipital lobes, the parietal region, and you have to deal with that. It's interesting that when we deal with the eloquent cortex, you must know exactly how far do you need to go as a surgeon. That's very interesting. This task force that was created by International League Against Epilepsy in 33 pediatric centers, mainly in the world, including ours, and they asked the neurosurgeons how they proceed in cases of involvement of these eloquent areas. And this typical picture that we have when we do this, if want to see, this is the ideal situation, a seizure-free child without any deficit. But you may have frequently seizure-free with some deficit. The problem is the seizure can persist and you have no deficits. The worst situation is deficit and seizures, and this is very bad. So when they ask neurosurgeons around the world, epilepsy centers, about 85 of the cases of the surgeons prefer not to run the risk of having deficit. And this may persist. The price of this is the persistence of seizures. Myself, I am in the 15% of the cases that we can tolerate some deaths in order to free the child from seizures, because we must count on the plasticity of the brain and the age of the child. And we must never forget that we're dealing with children. Sometimes it's the family, and we sure with this is we always talk to the families. We may accept deficit in order to get this patient seizure free. And this was published in 2018. It's very interesting to read. The other thing is language in children. It's not easy to exactly know when dominance occurs. We think that typically not before the first decade of life that is established the dominance for language. And this thing is, this can be relocated either inside the same hemisphere or even contralateral or frequently bilateral. And do not forget that atypical representation is common. We have to think in this maturation process and the children, this plasticity of the brain that should be considered. And this means that the language areas are not like in adults, are not, they are over a wide area comparing to adults. fMRI is not always we can get in children because the cognitive problems. And we learn a lot in children with the revascular problems that relocate these areas. So these are the main etiology in cases, in operated cases in a Center for Pediatric Epilepsy. As I said, the first number one cause etiology is cortical dysplasia, followed by tumor, and many other kinds of pathologies that we commonly treat. But we're frequently dealing with cortical dysplasia in these children. This follows the same in other centers around the world. In children in the epilepsy centers, the first technique that we apply, that we use, is hemispherotomy. It's a trend in many centers, followed by many other techniques, as you can see here. But this follows almost the same internationally. But if you think differently, you see that for extratemporal epilepsy, what we commonly do is lesionectomy or expanded lesionectomy and disconnective surgery. And this is interesting to note that this represents in a pediatric center, this represents almost 40% of the cases that we do in a typical case for epilepsy surgery in children. If you add this with the hemispherotomy case, you see that more than 60% of the time we're dealing with disconnections and lesionectomies and expanded lesionectomies. This is the typical framework for the pediatric and neurosurgical treatment. Let's see some cases. For instance, this boy, 6-year-old boy, you see that has a refractory epilepsy related to this lesion at the bottom of the sulcus. And as you can see here and here, and this can see also seen in the SPECT, the ictal SPECT. This boy was submitted to electrocorticography, and the electrocorticography was enough to define the epileptogenic cortex, and lesionectomy, a simple lesionectomy, was the only treatment for this case, as you can see here. Another case, the 15 years old child, again, epilepsy, refractory. This is the lesion very, very close to the motor region as usual. In this case, as a deep-seated lesion, we prefer to do this with stereo EEG. So we inserted these electrodes laterally, and we could, this is the map that we follow. And it is interesting that you can insert an electrode just inside the lesion. And so if you want to do surgery soon after this monitoring, you can, at the time before the patient leave the hospital, you bring the patient to the operating room, and you follow that electrode and find easily the region. This boy had a small deficit that cleared completely 1 month after surgery. This is what I mean, that a small deficit is acceptable, mainly a temporary deficit, but in order to have a child seizure-free. Another interesting case, this time with the temporal sclerosis patient. In this case, AMP PET that showed the read epileptogenic lesion. It's interesting to note that this patient was operated elsewhere in the wrong place. And this was one depth electrode, and a plate, a grate was inserted that show exactly the location of the seizure. The same kind of lesion, you see the lesion in the bottom of the sulcus, but in this, look at how close it is to the central region. And the problem with this case is that the epileptogenic zone, this is the region of the hand, fMRI, the epileptogenic zone was more larger than the previous one. So in this case, we treated with this grid that showed the very large epileptogenic zone, just close to the motor and the language area, and the patient could be in this, the motor region could be stimulated intraoperatively, and a larger resection, we call it a expanded lesionectomy, can be performed, and the child is very fine. This is another interesting case, a very small child with a tumor, a 2-year-old child. This grid was inserted in order to see the involvement of the motor region. And you see that in this child, the lesion is exactly over the central region, exactly over. But when you do this mapping, you see that the hand region is displaced, and we could resect the lesion. This child recurred 7 years after, and we redo the surgeries. You see how close it is to the central region, exactly over, and this child today is free of seizure. And again, this means when cases where we can go a little bit farther in order to treat epilepsy in children. And now we can apply another techniques, disconnective surgery. For instance, when we have multiple lesions, in this case, a tuberous sclerosis, tuber are multiple in the frontal region, we can disconnect these cases. Disconnective surgery is frequently used in pediatric cases, and we can disconnect the frontal lobe, we can disconnect the parieto-occipital region, we can disconnect the posterior quadrantic region. The main reason to disconnect instead of resect is not to create an empty space in small children. You know that hydrocephalus is a terrible problem. You cannot, it's not fair to treat one pathology and create a second one that can sometimes be as severe as the other one. So today we use very much these cases. For instance, in this child, a very small child, 1 year or 8 months of age, with this large lesion in posterior quadrantic region that was treated by this disconnection and preserving, as I said, as I mentioned, the brain in the same place and the vascularization. And this is the post-op MR showing that the ventricle remain normal, although a complete disconnection of the epileptogenic region. And finally, can we do staged surgeries is mentioned frequently. Staged surgery can be performed when you have the eloquent areas involvement. For instance, in this child with Sturge-Weber's syndrome, it's typically this child had the calcification in the frontal and parieto-occipital region. And interestingly, all the central region was spared, and the child didn't have any deficit, any motor deficit. So the family never accepted a hemispherotomy in this child. You see that a big angioma, posterior and anterior, as showing this the image here. So in this case, the first surgery we did is after this invasive study, we decided to disconnect the frontal region. And the child was fine for some time, for a long time, for some years. And then this is the surgery that we did, preserving the central region, but knowing that we had an angioma posteriorly. This is the image that we have planned, invading the face motor area, because this has a bilateral representation and can recover easily after surgery. In this case, this is the image. And she stayed well for some years. And then seizure recurred. And this was recently. And for this child, we decided to do a surgery that was proposed by Rasmussen in 1990. And he called it Subtotal Hemispherotomy. And this preserved the central region. As you can see, this is a post-op CT to show the calcification anterior and posterior and the line of disconnection in this child. And she's seizure-free now without deficit. But remember, reoperation is not easy. You have to rely heavily in neuronavigation because things may be so hard to find anatomically. So, in conclusion, extratemporal resections are common in children, and surgery can be performed, and it should be performed as early as possible. Invasive monitoring is a valuable adjunct, and I think nowadays we can use we are still using grids and strips, but nowadays steroidy is gaining much more attention because for children it's a very nice and elegant technique. as eloquent areas are frequently involved in these children. And you have to decide a more aggressive resection, meaning trying to free this child from seizures for life. We're dealing with children, and if you decide not to be aggressive, staged surgery is an option with all the problems that this may come with. And I thank you very much for your attention. This is we have in our center a pediatric epilepsy group, and I thank everybody for their work. Thank you very much. Thank you, Adrian. Thank you, Salman. And thank you, everyone.
That was brilliant. Really, I think you have crystallized this very important topic that in children, it's mostly extratemporal, whereas in adults, temporal lesions predominate. And I think you have also made a great point that especially in children, we must not wait. We must be very efficient in providing a good diagnosis. I think in many areas of the world, epilepsy has been considered among one of these chronic diseases, as hypertension and so on, whereas you just give medications and wait and see what will happen with the patients. But if you're able to identify early enough these patients who will not get control, you can actually do a great service by avoiding this epileptic encephalopathy, which will induce deficits with long-term outcomes. And I think earlier and earlier surgery is providing better and better results. One of my questions to you, Elio, is that, for all audience that is watching this, do you think that a stereo EEG is a must, or do you think that by doing grids and strips, you can achieve almost the same results?
Well, very, very good question, Adrian. Thank you. Yes, this is the point. We have been doing this for many years. I think the last 30 years doing surgery with the grids and the strips is very nice to work with. And the problem is that nowadays stereo EEG is gaining attention worldwide. It's a very nice technique. If I could, I would do mostly my cases with stereo EEG. But there's a problem. The problem is the cost. The cost of this electrodes is very, very high, and much higher than the cost of the grids and strips. The second problem is happening, we are seeing now, because these grids and strips that we had normally, they are almost disappearing, because people are tending to move to stereo EEG and not buying more these grids and strips. It's becoming difficult to buy this. So I think we will see some movement in this direction. Maybe lowering the price of this electrodes for stereo EEG, but keeping the grids available. Grids we still use routinely for ECOG. ECOG, I think, will never disappear. Even if you do a stereo EEG, it's frequently to ask our neurophysiologist, ask the surgeon to place a strip over the motor region just to stimulate and to be sure that you are in the right position. So there's a trend toward the stereo EG. I don't know about the future.
There is a question here from the audience. Uh, so one of our colleagues is asking that is there any role of awake craniotomy in the case of eloquent area surgery? So in your center, Helio, what is the youngest age you will consider to perform awake craniotomies in children?
Again, this is a very good question. Another good question. We don't do awake surgery in children. The main reason is, you know, epilepsy is such a complicated problem from the cognitive and behavioral problem. A child is almost 80% of the children that we see have cognitive or behavioral problems. It's very difficult to try to do awake surgery in children with a cognitive delay, and we never try to do that. So I know that in some centers you can do, but you must select very, very carefully your patients. So our neurophysiologists prefer to insert either grids or stereo EG and stimulate the child in the clinical settings, in the clinical monitoring setting with the video EG in a awake child, very patiently. It takes days, I can assure you, days to create a map, a very good map, language map or a motor map, and instead of trying to do this acutely. I don't see any reason to submit a child to awake craniotomy.
Great. Other question that could benefit the audience is that, as you know, Amital has been very scarce around the world. And nowadays, functional MRI has replaced many of the language mapping process. Many years ago, we actually substituted Amital with intracarotid propofol, and we got very good results in children. Are you still doing any WADA testing in older children?
No, no, we totally abolish WADA test. The reason is first, the reasons are that you mentioned, the disappearance of Amital, but we still have propofol. The problem is that you anesthetize the one hemisphere, the good one. We start with the bad one. And you want to study mainly language and sometimes memory. And it's not easy to study with children with cognitive problem in this case. And a child, somnolent child will never ask adequately. So with time, as in the many centers in the world, we totally abolished this for children, and we rely on fMRI. And this forced our neuroradiologists to improve their technique, and in such a way that is today we can obtain a technically very, very good fMRI even in small children.
Thank you, Elio. I see that Shekhar is around. Are you there, Chandra?
Chandra, I just unmuted Chandra. Chandra, you want to unmute yourself?
Okay.
Okay,
If
just
not,
just a question, Helio. What about you're saying the improvement in functional MRI? We used to have a lot of trouble. I don't know how you managed to overcome with small kids. How do they interact when you're doing the functional MRI with small kids?
Yeah. When I see our staff playing with these children, it's amazing. They start playing. The psychologists and the occupational therapists make these children confident before going to fMRI, and I think that you can always have that after 5 or 6 years of age. But as I mentioned, for me, the motor region is easy to obtain. It's easy to elicit in the fMRI. Language areas are really not important for me before the age of 6. It's interesting if we have, and frequently we discuss with our radiologists when and we see bilateral representation. It's very common. So you'll see actually you're dealing with older child, and sometimes it's easy to obtain the exam, the image study.
And Helio, what about the new stuff that you're saying with functional MRI, the new stuff they can do to improve elicit the results that you want them to show? What new techniques have come in recently which have changed? Then we're just saying, okay, we trust functional MRI.
Yeah, there are new techniques. I cannot talk about that because they are coming, and they are coming to the all over the centers, and I'm sure. I'm sorry, but that's not my role to mention it properly. I know that these techniques can be used, but they are very new techniques, and the neuroradiologists are starting using. And this is, at least in our center, it's not routine.
Okay, what about, there's Mohammed Nadeem who's asking a question. He's asking, where do you use vagus nerve stimulator in kids?
Yes, interesting now that there's a new trend toward the neuromodulation techniques in children, in adults, sure, but also in children. Vagus nerve stimulation is good. We have used it in our children. I think results are absolutely, I would say that they can be a little bit better than in comparing to adults. And at least in our experience, at least 60% of the children have more than 50% reduction of seizures. It's a good number. And the other thing is the improvement in behavior that we see with children. It's incredible to see that the children become happy. They just reduce the rate of seizures, but they are more easily managed by the parents, the mother that take care of these children, and they feel much more happy than they were before. I think it's a good technique. There are two problems. We had some cases of infection. When you place a vagus nerve in a small child, that's not well nourished, and with the skin is very thin, and you may sometimes have local infection that can treat without taking the VNS out. But so we had some case that we lose the system. The other problem, again, is the price. It's very expensive for countries like ours, and now we can have it for patients that have a sort of payment for their health care. But for public patients that comprise almost 70% of our population, this is not routine for the public services. So that's one problem. But I think this trend will show very interesting things, deep brain stimulation and other techniques of neuromodulation will be in the near future common practice in epilepsy centers in children. And they are indeed in some centers in North America and Europe.
Chandra, would you like to say something, please?
No, I just wanted to supplement what Dr. Machado was saying. Basically, the question which was asked about vagal nerve stimulation, I think does not belong to resectable lesions. Am I correct, Dr. Machado?
Yeah, correct. Absolutely.
Talking about temporal resectable lesions. And is there any condition there where you would use a vagal nerve stimulation? I think most of them you would prefer to do a resective surgery.
Yeah. Yeah, and that's the reason, Chandra, that I mentioned that in our center, I don't know in yours, but in our center, we accept to run some risk of deficit, mainly temporary, but sometimes persistent deficit, in order to get one child seizure-free. Seizure freedom in childhood is essential for the whole life, you know that. But as I mentioned, in many centers around the world, they do not accept, families do not accept, and the surgeon do not accept to run any risk. In this situation, you know, treat or have good results in epilepsy surgery is very difficult. The percentage of patients seizure-free come from 75% to 40, 30% when you leave lesion behind, and that's a problem. In these cases, you try to place a vagus nerve and everything, it doesn't work. Anyway, I prefer to go a little bit farther. I don't know. What about you?
One more comment and a question. Comment is about the techniques of doing various mappings or doing functional MRI. I think the child neuropsychologists find very good ways, and they come up with paradigms where they can probably do it much better. And we have actually been able to do awake surgery in children above 8 years. At least half a dozen cases we have been able to do, but not below the age of 9. I think 8.5 years was the youngest. The other question I have is that how different do you consider cavernomas compared to tumors or FCDs? Are the selection criteria the same?
The same. We didn't have time to discuss all the etiological process, but cavernomas are, we do the same thing. And we rely on the complete investigation in order to either to resect, to do a lesionectomy, a simple lesionectomy, or an enlarged or a lesionectomy in these cases. I think it's the same. It depends on the duration of the seizures, on the age of the child, and but frequently the great majority of cavernomas are not treated in the epilepsy setting. They are treated in our pediatric neurosurgery department without any investigation. They are only treated when they have seizures or multiple lesions, eloquent areas lesion, deep-seated lesion, and epilepsy that is very difficult to treat.
Thank you.
I think there's another question by Anwar Haq, and he's asking what is the indication and his role of magnetoencephalogram?
Yes, magneto is great for when you have it. It's you know, it's an excellent technique. The problem again is the price. You can rely on other methods without MEG. But if you have MEG, I know that few centers have MEG around the world. It's very, very nice to have it. It's will facilitate this pre-surgery approach.
Okay, so shall we see the questions, Imad?
Imad?
Sharing.
Imad? Thank you.
So I reorganized your questions, Helio, so people could answer. So your first question was, how frequent are extratemporal resections in children with epilepsy?
Yeah. At least 30% of the people did it correctly. I think it's okay.
Okay, let's go to the next one. In selecting patients for surgery in extratemporal epilepsy in children, is it necessary to use invasive monitoring? And what kind of monitoring?
Well, as I said, this is not needed in all cases. And
so the right answer would be?
So it's needed in around 33% of the cases.
Okay, so that's very good, because you know people sometimes will hold back and think that if they don't have all the adequate tools, they might not benefit children who definitely can improve. Next question. Surgery in eloquent areas in epilepsy in children. Can you perform surgery in eloquent areas in epilepsy?
Yes, carefully chosen patients.
May have temporary deficits and good results.
May have temporary deficits, good, excellent, excellent. This is excellent. Okay, very nice. Mission accomplished.
So people got the message, huh?
Yeah.
So we really like to thank you, Salman and Chandra. Do you have any words?
Chandra, please.
I think it's been an excellent talk and conveyed all the right messages.
Thank you.
I think I'd again say that, you know, just like with the tradition that we've had with pediatric neurosurgery talks, all have been brilliant, and another good one here. Really enjoyed that and learned loads again. And it's good revision. And for people who are young neurosurgeons who want to be doing pediatric neurosurgery, I think that this was brilliant. Can we show us what we have for, yeah? So what are we going to do with Jeff? Is he going to give a talk in a separate session?
I think that in order not to lose the you know, the stream of epilepsy. I will probably will let my space for Jeff to take over next week. So next week, Jeff can talk about hemispherectomy, and Sandy will talk about callosotomy. And so we'll just make this change in the course.
Okay, and it's important to know that next weekend, because of ISPN, we will not be having this webinar, but we'll go with ISPN.
It is a free webinar for everybody to join. I think it's a great experience for people to learn from all the masters. Topics will be great. And by all means, I think this is a great way to get acquainted with the ISPN. And if you're interested, please join. It's a great group of pediatric neurosurgeons worldwide. So it will be a 3-day, it's a free admission. You just have to register.
Okay, brilliant. Can we have a group photograph, please? Can we all switch on our videos so that we can have a group photograph?
That the next session would be on 14th of November.
Yes,
Yeah,
Chandra. So we'll skip next weekend for the ISPN to take place, and we'll see each other in a couple of weeks then.
Great.
Thank you for.
Okay, can we have the group photograph? Are you ready?
Sir, I'm ready.
Okay, can you switch on videos, everybody, and smile? Chandra, it's okay to smile, please. Are we done?
Yes, sir, we're done.
Brilliant. I know I'm again grateful to Helio for such a wonderful talk, and Adrian bringing the best out of him as well. So, we'd wrap up here. Adrian, your last comments before we close. Sorry, Helio, you have to give comments before we go.
Okay, thank you very much, Adrian and Salman, for this opportunity. And I think that discussing these topics in a pediatric neurosurgery context is very important. Sometimes people think that epilepsy surgery is only performed by epilepsy surgeons, and this is not true. Because we are more trained to deal with difficult problems, complications, and small children. So thank you very much for this opportunity, and see you soon.
Thank you, Helio. Thank you, Salman, for holding this platform. We have a consistent 120, 130 participants, and everybody has been very pleased. So I think we're improving and advancing pediatric neurosurgery. Thank you, Chandra, for attending and always for your support.
Okay, guys, thank you. Enjoy yourselves. Whatever weekend is left.
I think we'll see some of you next weekend as well.
Yep, definitely.